Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. For related lecture, you can go and check these two clips. And very soon, the series for myocardial infarction, the collection of the many topics in myocardial infarction will be published and uploaded very soon. In less than 1 to 5% of the patient with myocardial infarction, we will have mechanical complication that top of those are from the highest to the lowest: free wall rupture, ventricular septal rupture or post-infarction VSD, and papillary muscle rupture. The incidence of each of them is less than 0.5%, but as I said, from top to bottom, this is higher, and then VSD, and then papillary muscle rupture. In this lecture, I am just focusing on the ventricular septal rupture, or VSR. VSR has two types, anterior and posterior, but it's not only anterior posterior. Sometimes is at the central or middle of the septum, but most of the time it happens at these two levels, anterior and posterior, mean close to the interjunction of the right ventricle to the left ventricle at these two regions. There are some differences between these two types. Anterior VSR usually happen in anterior infarction, and usually with one vessel, that is LAD, involved, and most of the time there is a localized blockage, not diffuse, and there are not too much collateral vessel. And this type usually happen close to the apex, usually, but not always. And the survival rate on this type is almost 70%. Posterior VSR usually happen at the interjunction posterior of the septum and the base of the heart, instead of the anterior, that anterior VSR usually at the close to the apex, but posterior type usually happen at the basal. And another difference is that in the anterior VSR, usually the shunt is straight and direct, the entrance and exit at the same level and direction. But in the posterior VSR, many times, or more common, is a spiral or oblique shunt, means the pathway of the blood from the entrance goes through the ventricular, some oblique pathway and tract, and finally from different location come out and exit, and so which the input and output, or inlet and outlet of the shunt, will not be at the same level. You have to keep in your mind later, I am going to explain about that. In this type, usually we have inferior infarction and multiple vessel, that mean RCA and LAD both involved, and survival rate on this type is less than about 30%. Here you can see the blood supply for RCA that involved in the posterior VSR is at the base, and at the mid of the septum usually we have overlap between the LAD and RCA, and anterior of the septum blood supply by the LAD, and that is the reason when the septal or posterior type, usually we will see on RCA and multiple vessel, and in anterior type we will see in single vessel coronary disease, that LAD. The classic clinical presentation of the VSR, or ventricular septal rupture, is a deterioration of the clinical feature of the patient. In other words, we have a patient that has known acute myocardial infarction during the first 5 days of post-myocardial infarction, but up to the 1 month after acute myocardial infarction, suddenly patient represent with the new pain, chest pain, or worse chest pain, and develop a shortness of the breath, and depending of the severity of the shunt, maybe patient represent with the low cardiac output and multiple organ failure. So just remember, whenever the future of the patient, a known MI patient, during first week especially or first month, suddenly the future change or new symptom, always we have to think about this complication. But you have to remember that 20% of the patient with the ventricular septal rupture, they don't have chest pain. There are many reasons because of the risk factor in those old age, usually women, and they have some other risk factor like diabetes, high blood pressure, anemia, and so all those other risk factors. So they will not have, they don't present with the classic acute myocardial infarction. The free wall rupture, usually patient in less than few minutes will die because of the right after that patient get cardiac tamponade and cardiovascular shock. If it's under our observation, the patient is in ICU and suddenly you can see the patient get electromechanical dissociation. You can see still EKG, but you don't have pulse, and patient goes to the shock. And unfortunately, most of them will die in less than a few minutes before we have time to take them to the operating room and surgery. The other two types can represent very similar like each other, doesn't have too much clinical feature differences. The only finding that can help us to diagnosis in the clinical exam is a murmur in VSD, post-infarction VSD. We will hear a pun or hollow systolic murmur that we can hear at the left lower edge of the sternum, and that radiate to the right side. And we can usually touch and feel the trill with the touching at that area. But in the papillary muscle rupture, we usually hear a little louder and low pitch murmur that is more significant in the apex, that can radiate to the base of the heart, and we don't have trill on the papillary muscle rupture. Generally, whenever a clinical feature of the patient acute myocardial infarction change, we have to always think about these complications. As I mentioned many times in many different lectures, as a tech, if we don't looking actively in those situations that we have to focus and put attention, we can miss very easily. For example, here, if we have a classic location of the shunt, for example, here anterior at the close to the base of the heart. Imagine this is base of the heart, even is not, but imagine this is base of the heart. We have anterior VSR. In that case, very easy, we can detect on the apical tree or plaques view. Or we have some shunt or VSD at the level of the middle of septum, we can see in the apical four-chamber. And when we put color, even we don't looking there, if you put color here on the left ventricle for the mitral valve or for the tricuspid, suddenly we can see a very clear jet that in this case very obvious. We have left to right shunt with two jet because of the presentation of the moderator band. Many times when we have ventricular septal defect due post myocardial infarction at close to the septum apex, usually it gives us this pattern. But as you can see here in this case, Even we did color on the cover the septum. Even the patient had VSD due to infarction, but we cannot see jet, because as you can see here, if we have at the apex of the anterior apex, that this is exactly this one, we don't see papillary muscle at this level, and apical tree is it doesn't, many times at the close to the apex, doesn't give us very clear that level, and we can miss the jet because it's close to the interventricular septum at junction of the right ventricular to that one, so we can miss it very easily, this view with the little fan completely out of the axis. Or on this one posterior at the base, all classic view that we have four chamber, this one is off, we cannot see detect the jet here. For apical 3, this one we miss it. For apical 2, this one apical 2, so we can miss it very easy posterior type of the VSD. And I'm going shortly explain exactly what rules we have to follow to not to miss this complication of the myocardial infarction. Here are some rules for detecting ventricular septal rupture. First, whenever we have myocardial infarction, or in better word, whenever we have abnormal valve motion, especially dyskinesia, like you can see on this case, we have dyskinesia between the apical septal and mid septal, this spot, you can see this spot. Whenever you see any valve motion abnormality, always you have to get extra image. What does mean extra image? You have to put color at that area and then sweep it, that area, depending on what view you are, sweep it from the base to top. For example, in apical 4, you are here, you see a dyskinesia on this spot. You have to put color there and start from basal view, means fanning down until your four chamber disappear. Then slowly with the color fan up toward the roof until you survey all the septum to the anterior, and slowly watch that area if there is any abnormal jet or not. For example, in this case you don't see anything, but when you sweeping the septum from the base to the anterior, suddenly here is anterior to the basal, opposite way. At the basal view, you can see this appear is coronary sinus, this is basal view. At the basal view, you can see this jet at the close to the apex at the septum, very clear. So don't forget, sweep that abnormal wall motion and in different direction. For example, if you are on the plaques, your plane is this way, sweep to the left and right of patient and make sure you check the septum in all direction. Or if you are apical 2, here apical 2 goes here, fan to the slowly to the right of the patient, tip of the probe in the apical 2, fan to the right of the patient, you become off axis, and suddenly you will see this jet at the level of the base, very easy, might be inferior, at the level of the inferior wall. Second rules, whenever you see any abnormal jet or turbulence inside of the ventricle, for example here, we have one jet here, TR, is belong to the TR, but right away you have to ask yourself, what is this jet? Is that mirror image? Doesn't make sense. Mirror image should be usually below that. If it's mirror image second, this turbulence is different from that. When you see any abnormal jet turbulence inside of the ventricle, left or right, doesn't matter. Or here you can see abnormal jet at the level of mid of the right ventricle, here turbulence, watch there, below the moderator band at this level. You have to, two reasons for that. First, We have some intracardiac obstruction that give us high gradient and turbulence, like this one or this one. Or second, we have a shunt. In each of case, you have to go and find it, where is the source and what is cause of that turbulence at jet. If it's on the left side, it can be, for example, hypertrophic obstructive cardiomyopathy at this level. If you put continuous, if we have obstruction, it gives you dagger or saber pattern that you can rule out with the Doppler. Otherwise, 100% will be shunt, intracardiac shunt. That at the beginning usually is the left to the right side. The third one is here. Sorry, before I go there. Here, you can see on the P-axis. Don't forget, when you have wall motion abnormality in any spot, always do searching and surveying with color at the P-axis too. Here, you can see abnormal just suddenly show up at this interjunction of the right ventricle and the left ventricle here. If you put continuous, and always you have to put continuous on that overjet whenever you have any turbulence or jet inside of intraventricular cavity, any of them, you have to put cursor continuous and detect Doppler on that jet. If you put here continuous, you will see a high gradient if there is any shunt. If it's artifact, you can detect it, there is not will be any Doppler. And another tips is that whenever you do continuous, for example, you are doing on tricuspid or mitral, doesn't matter, you see bidirectional jet and high velocity. For example, here is close to the 5, 6. If you see bidirection, there are two reasons. First, your cursor hitting a horizontal, perpendicular to a jet. There is a jet, whatever it is, you are perpendicular hitting that jet, but it shouldn't go, if it's normal jet, for example, TR or MR, it shouldn't go very high because perpendicular usually doesn't give you very high. One of the tips is that one. The second, it should be a shunt. There is a shunt. So you have to follow and find where is that source of the shunt and Doppler you see on your study. So, one more time, any abnormal jet, you have to think about the shunt. Any wall motion abnormality, you have to put color at that each level of those abnormal wall motion and sweep it that wall completely, all dimensions. And third, when you see high velocity Doppler in any spot that especially is bidirection, you have to find it out what is the cause of that jet. Here is the previous patient. As you can see, we can catch it on the apical 2 beside of the apical 4 at the basal view. We can catch it with the same technique, sweeping and fanning to the right of the patient or left, doesn't matter. You have to sweep it that area. You can catch it very easily. So don't forget, all the time go off axis for any kind of the jet. Here the same again patient, we found it another second jet at the level of axis. So don't be satisfied and don't assume if you find one abnormal that is done is enough, it doesn't have another abnormality, because the prognosis and management and treatment is completely different when you have one jet or two jets. And if you miss it, so the repairing, if we make decision repair and surgery, so we can miss very easily. Don't forget, always sweep and search. Don't be satisfied only if you find one abnormality. Many patients they have 2 or 3 abnormal finding at the same time. After detecting, we have to do all Doppler study and do VTI and all those protocol that we use for any intracardiac shunt. that include calculating Q P over QS that I'm not going to explain on this lecture. I explain in two different lecture. One of them is heart failure and physiology of the heart, part 1. You can go and check how we calculate QP to QS. For treatment, if we postpone more, if we can, the situation of the patient let us, if we postpone more and give enough time to the myocardium repair and all necrosis area demarcated and collagen deposit, is much better the prognosis of the surgery. Usually in those patients that hemodynamically are stable, if we postpone 1 week, the result and prognosis will be much better than if we do surgery in emergency situation, especially when a patient hemodynamically is not unstable. The general survival rate after surgery is something between 40 to 50%, average 50%. We are done. Up to the next time. Have a wonderful time.